So first we will start with this, what is called expertise mediation. I think that must be, I googled it and checked what that could mean, but I think it fits well with our case and our example. It's about trying to have experts working together, producing new services. And this case from health service is very much about that in our region. This is this first case, this first example. That's something I've been working quite much with also, and together with a colleague that unfortunately has gone back to the University of Bergen now. But I will come up and present the results there. The second part, which is on evaluation of web services, that's basically work done by one of my colleagues. I'll be back to that later. He is at a conference today, and I have to try to present it as much as I can. I don't know, maybe you also can ask questions on the way here. I don't know really how long it will take, but the first one will probably take a longer time than the second one. But anyway, the first one, expertise mediation, as an example from our region, and my presentation is organized like the following. I will say a bit about the regional framework, why we are doing this, and what's the setting, what's the starting point. Some of the challenges, because this was quite a difficult area in the start. Almost nothing happened, a lot of technical trouble, but then suddenly everything happened. It was like a famous catch-up effect. Nothing happened and nothing happened, and suddenly everything happened. It's also based on long-time regional ICT collaboration, which is very important. It's based on some progress. And then I come into how this is done. So maybe I have to, to talk louder then. Is it better if I talk louder? This is better. Okay, good. I will try to talk louder. What you see here is my presentation, what the content will be. First, some from what is the starting point in the region, what was the challenges, what was the trouble, and how things started to happen quite quickly, and it has been quite successful, and it's really have changed the whole situation in the region when it comes to e-health and especially electronic messaging within the health sector. And we have also done evaluations around this, and I will give you some information from that, and some results and some recommendations, which I think we can build into our project and our next activities, and also have some references to articles and research. First of all, just to remind you about where we're coming from and the region. We are from a county which is called Sogn og Fjordane. It's Sogn and the Fjords. There will be a lot of references to this in the rest of the presentation. And it's in the west of Norway, and it's a very rural area. It's one of the most rural areas in Norway. Only in the very north it's less population per square kilometer. We have one county municipality, there's one of 19 in Norway, and we have 26 municipalities in the region. You can see the names of them at the map to the left. And there is only 108,000 people in total in the region. So if you divide that by 26 municipalities, most of them are very, very small. There are maybe 2,000, 3,000, 5,000 people. There are even one less than 1,000 people. The biggest municipality is the one in the middle called Stød. That's about 11,000, 12,000. This is a very important starting point because they are small. There are few people covering huge knowledge areas. And because of this, they are quite used to work together, either in sub-regions or even in the whole country. And as you can see from on the very lower text there, it's a region based on natural resources. You have heard this before, but it's like fish farming, fisheries, hydropower, tourism, agriculture, and so on. Okay. What about sound now? Can you hear me better now? I have to try to find the best place. Okay, I'll be very stable here now. These were the challenges when we started this activity. It was around 2010, 2012. There had been a lot of problems with e-health projects. The national e-health infrastructure had come in place, but that was just the broadband part of it, connecting all hospitals, connecting local doctors, and so on. But the problem was that when we looked at the different systems, the systems that produce the content, there were different systems and there were competing systems. We had some pilots, which was very promising, and they were up and working, and then suddenly everything collapsed due to technical standardization, or the lack of technical standardization. There had been national standardization programs, but they had not really fully standardized the systems, so it was a huge interoperability problem. And then some of the technical providers, they just updated their software, and then everything collapsed. So this created a lot of frustration, and everything basically stopped for 1 to 2 years. And it was a big problem because the whole e-health service potential was not at all realized. It was really so bad that it was even worse almost using technology or IT technology than doing it the old way. Because when they tried to send electronic messages, they didn't trust the system, so they used a telefax in addition, just to be sure. So it was really a double work using the new system. So then something happened, and it was extremely important. We had a new national health reform in 2012, 2013, and that was really the game changer, because then it became very serious. Can you hear me now? Is it okay? Yes, good, perfect. This health reform, that was serious in the way that it was kind of an efficiency reform, and it was a reform that should sort out the collaboration between hospitals, the specialized healthcare, and the local healthcare system. They should, of course, work better and more efficiently together. But then, from point 2 and down, the important thing came. The patients, when they were finished at the hospital, they should return to the local level faster and without delay. And then number 3, if the local municipality were not prepared to take care of them, or there were delays, then the local municipality had to pay hotel price for the extra days at the hospital. So this was really cash out, and this, then the managers, the mayors, and the head of administration, they really understand that now something had to be done. It had to be more efficient. And the information, of course, has to follow the patients from the local level to the hospital and the way back and so on. And then there were some meetings saying that all the key players agreed these ICT solutions are now absolutely crucial for the success or failure of the reform. The reform wouldn't work without this being in place. And then we are back to some of these IT organizations in the region. One important part is we have an IT forum which has existed since mid-90s. It includes all the key players. If you look at the top of this figure, you see IT Forum General Assembly. That's where all the key players in the regions are. They decide on strategies, and they decide on where should we now put some funding and where should we try to have some big activities and projects. And if you look at the very bottom, the main strategies for now, that's e-health and welfare technology. This has been for quite a few years now. Broadband infrastructure is another one, because that's of course the basic infrastructure, where e-health is the content and provide a network that will do businesses. But this system then decided, now we really have to do something, and everyone has to support it. These are the members of this IT forum, and when you look at this, there are several here that are really our stakeholders when it comes to e-health. We have the county governor, which is looking after the representative of the government in the region, looking after the municipalities. The county council, which is the county political body. The university college are dealing with education in this. The Association of Norwegian Municipalities, that's all the 26 municipalities are organized there. We have regional hospitals, and we have ourselves, which are doing research on this and also development activities. This whole system said, now we have to do something. All the management, all the specialists really have to support it. Then there were two projects, or two phases of a project, which was funded by some regional funding, plus funding from the municipalities. And those projects, they were the red arrows there. In 2012, 2013, it was about the collaboration and the electronic messaging between the local doctors and the municipal elderly service, that is within the local area and the local municipality. Then, when this was up and running, then the next phase was to work with the services from the local level to the hospitals, to the regional hospitals. At the same time, the regional hospitals had their own project dealing with the communication between hospitals and the local doctors. So this triangle, that's the key elements, the key players when it comes to the e-health. And these electronic messages, they have to flow through this whole system. Because the patients are linked to the local doctor, it could be linked to the local municipality elderly centers, and then it goes to the hospitals for special care and comes back, and then these messages have to follow the patient. These are type of messages that's sent around. It's when you look at the right-hand side, in the doctors in the hospitals, it's the medical records, it's the references when you send someone to the hospital, and it's tests and test results. On the red side, it's again reports when arriving at the hospital, update of reports when you come back, medication. Before this was working, many patients actually came back to the local municipalities, and the medication, the updated medication, didn't follow them. So they didn't really know which medicine to give them. It was quite fantastic, so maybe quite disastrous. It's logistical messages, it's acknowledgement of receiving the messages, and so on. And this has to flow between the different players there. So the project was then about how can we get all the 26 municipalities, the whole country, up and going. Before the project started, the region was quite behind. When the project was finished, then all the municipalities were up and running. And one key thing is about this is how it was organized. And I think we have learned a lot about this, and maybe it's almost like an organizational infrastructure. And in our next step now, which I will just briefly say a bit about at the end, is welfare technology. We are using exactly the same strategy and the same organizational solution. The first key player is this IT forum, which I showed you. That's all the managers, all the mayors, all the regional directors agreeing on the strategy. So if something stops at the local municipality, we can go to the mayor and say, come on, you have agreed on this. You have to do something. When it came to maybe ICT personnel, they are in the broadband activities in the IT forum, and we know them. We can go and say, come on, it's not working, something must happen here. Secondly, there is a working group in IT forum, which we saw all over the e-health group. That's the group that is doing the project management and the coordination. And that secures also that it will cover all the region. In addition to that, there are two very important other groups. There are really many groups. There are one project organization in each of the municipalities. And it was very important that if you look at the three different group of expertise, they have to work together. It's the doctors, it's the municipal health service, that is the people taking care of the elderly, and it's the ICT people. Normally they don't, at least the ICT people, we are told, they're not so much in contact with other groups here. But during this project, we got up and running with 26 small project organizations involving these people, and that was really key. Because then they could discuss, they have to go together, they have to get it up and going themselves. Each of these groups had made a small project plan based on a model and based on some checklists. I will say a little bit about that. And then they made their own timing for the installation, for testing, for new routines, and also for developing new services. Because this was a new way of working, so they couldn't just do it the old way. They had to do it in a different way, or partly in a different way. In addition to this, we had sub-regional groups. As I said, this region consists of very small municipalities, and they are used to work together. There are basically 3 sub-regions within the county, consisting of 8 to 9 municipalities, and very fortunately, they were having, in each of these regions, they had the same software. So then they could make a subgroup on each of the software solutions. And one of these municipalities in this region, they took the role as a pilot and mentor. They started to do the testing and implementation and training, and took out the first errors. And then it was much easier for the rest of them to follow up. Sorry. This type of organization proved to be very important. And it was also no way that we, like I was part of number 2 here, the project management and coordination. It was no way that we could coordinate 26 municipalities. That was coordinated via the sub-regional groups, and we had contacted those groups. Another thing which was very important, and I think it's a good learning, is that we had some basic checklists what to do. It was first developed with this pilot municipality, and then it was used by all the others. This was about getting started, of course, but it was for planning and making local version of the project. So everyone had to make their own version of the project, where they planned the timing, the training, who should be involved, when do the testing and implementation, all agreements have to be in place when it comes from certificates for the IT part to who is doing what and who is responsible for routines. Risk assessment was an important thing because it is health services, of course, and the project as such also made that. Responsible people, contact people, and who are the resources in the group. Everyone made it. There were 26 versions of that, based on the pilots. And we also tried to then, when we evaluated and when we had meetings, we tried to update it, to aggregate the new knowledge back into this checklist, because then we had a platform for learning and a platform for improving activity. I think this is the key of what happened. This is just the names of the municipalities again. It just shows that there were 3 different software systems here, health systems. It's the systems used by the municipal healthcare services. That is to record everything going on, medication and everything that's happening. But fortunately, as I said, the 3 systems really had a regional implementation. So some of the municipalities that already used to work together, they could use this they could take this up in their group. The red municipalities, Stryn and Flora, they were these pilots. They did an excellent job. They were interested, they get some extra resources, and they did the first test, and after that was working, the others came quite quickly. And by summer 2014, June, I think it is, then everyone was up and running. And that was quite remarkable. We didn't really almost believe it could be like that, because there had been so much trouble over the years. And this region also was one of the first regions or counties that was up and running with all their municipalities. Now almost everyone is up all over Norway, but this was one of the first. And there you see the map again. The green, the blue, and the yellow plus violet, they were the 3 regions, and the H, that's the hospital. So the information or the messages is flowing between all this. Okay, so to some of the results now, key results for the user groups. They clearly say that has saved time. They have better collaboration. Things are going more quickly. And it's quite obvious when previous situation was that when a patient came back from a hospital, the medication documentation didn't follow the patient. That was, of course, okay, too difficult to hear. Maybe I have to speak louder again. Of course, it was disastrous if you didn't get the documentation. Now it was coming. It improved safety for patients. Information is recorded. It's not only on like oral information, which is maybe is recorded later. It's immediately recorded. It's better quality. It's about the same. Saved expenses. They call less. And of course, faster information flow. They also say that now when they have to make it more written, it's more formalized. In the older system, it was more, say, oral messages, more fluffy messages, and now they say that it's clearly a better quality. And they also say that the final conclusion really is that we could not have implemented this new health reform without this technology. There was too much to do now. There was too much pressure. So the ICT fundament had to work. And I think, of course, that's part of the reason why it's been working. We have also done an evaluation activity at the end of the project. It's a combination of questionnaires to the municipalities and some interviews. An interview is done with the local project group, doctors, the healthcare people in the municipality, and the ICT. As I said, these are different municipalities, but they are very small. One was less than 1,000, and the biggest was 11,000. If you look at the score here, this is 7 from 7 municipalities, and the score from 1, which would be very poor, to 5, which is very good. And it was a very good score, except for 1, which was more medium. And I think this number 1, that's the smallest municipality, so they basically said that they had already very good communication, they were working very closely together, so the difference wasn't that big. But for the other ones, you see it's a very big high score. When it comes to the project as general, when it comes to technical implementation, the routines, and so on. I think some of the reasons for that is also that it was a bit surprising that it worked so well. There had been so much trouble, and they saw that they needed it. It solved the problem. And we were really trying to find out, provoking almost, where could there be some problems. So there were some problems with the technology in the start, but in a way they forgot it when it was starting to work. Some other feedbacks here, which is some of it quite interesting. They looked at, of course, ICT is quite difficult for many of these people involved in the health services because they don't have any technical education or ICT education. They're not used to work closely together with the ICT people. But it worked. We said they were amateurs, and we don't even know what this is, but it actually worked. It wasn't difficult, because we wanted so much. And they also said, this is learning by doing. It's very important. You cannot plan forever. You just have to do it. Jump into it. And it was very important that in these groups, there were some super users, there was some enthusiasts, that people want to do something. And that was also back to this pilot municipalities. They liked what they did, they were proud of it, and then they would like to help the others also. And it was also fun to see a project where you could see the benefits so clearly. And we have become proud of ourselves. There was some proudness in using this new solution. Some learning from this, and what we can, well, for sure we are now taking into new projects, and especially on this welfare technology, which is the next phase. It's very important to see that it's useful, obviously. That is the feedback all the way, and it was really also from the start. This had to be done. It's very clearly linked into the reform. They were not able to do the reform. It would be a failure if this wasn't working. So I think this is one of our clearest cases where we've seen that the user needs are so strong, and it's linked so clearly into solving the real problem. Then it's much easier, of course, than doing some project with some dubious needs. The local project groups, they were very important. Establishing this, I would say, cross-sectional project groups were very important. So the ICT people had to work with the health people. That was a bit new. And also the doctors and other health people had to work together, had to define routines, had to define how we should monitor this, how we should give feedback if something was not working. That was extremely important. So they realized that they were actually improving the whole service delivery by working together like this. And of course, commitment at all levels. Here it was both on the regional level and the local level, because it was trying to lift the whole region. But that also, it was very important, because if something stopped in one municipality, we could go to the mayor, or we could go to the head of administration. Come on, you have decided this, together with all the others, that we should be up and running. And it was agreed on the management level and by the specialists. So this commitment all over it was very important. Resource persons, that's nothing new, but it is again seen. Very important to have these resource persons, and they have to have resources, they have to have hours, they have to have funding, so it's possible to do the job. There are a lot of people that are enthusiastic and interested, but there must be room for them. Then they could be very helpful for their own organizations, and obviously also for other organizations. The two municipalities acting as pilots, I showed you Flora and Stuen, that was absolutely critical, because then we could start there, solving the technical problems that were still around, and then when all the others should do it, then that was solved. So we didn't have 26 with problems. And then they could contribute with the knowledge, with experience, with the updated manuals, updated checklists, and so on. And they were also motivators, because they were being the leading municipalities. They got the proudness to that, and they were motivators for the others. Also, this thing about learning by doing, we have to jump into it. We can't plan everything to perfection. Then we don't get started with anything. But again, it's back to have some pilots, some get going, some motivated people, and then the other could follow up. They also said that one important thing was when you got into this kind of a positive circle or mood, then the focus was very much on help, support, and encouragement. It was not about complaints and complaining about things that didn't work or were difficult and needed work. It was more like they came into a positive circle. And this was also very clear feedback from all the municipalities. And also this having room for learning, there was enough time for learning. And I think that was also a result of having so many in here. So there was someone was prepared to start, and then others they needed to wait a little bit. So at the end, it was room for everyone to learn and to learn from each other, and then get started. And finally, this checklist, that was a very simple way of make sure you think about all the key elements. Make sure you can make a time plan that is realistic. It was also a huge issue for all the ICT providers, because with so many municipalities all over Norway that needed courses, needed implementation, that was a big problem for them. They need to time everything. So then everyone had to agree with the providers each month they could come and so on. And altogether it was a big process. And this checklist has also been very nice an instrument for aggregating knowledge. When we learn, we can feed it back into there, and it's going to be a simple tool for new municipalities or for new type of services. The next step we are working with now, this e-messages. There are of course many e-messages that's many health messages that's not implemented. It's like to the pharmacy, to the physiotherapists and things like that, and there are more messages with the hospitals. But that's now kind of on the track. They are implementing those things. So the next main activity now for new initiatives, new services, that's linked to welfare technology. And we are basing that very much on the same type of organization, on the same model for working. And this is about how people can live more at home, longer at home when they are old, or people with special needs, and like smart houses with all kinds of sensors and communications to specialists, so on. We are doing exactly the same now with all the 26 municipalities. Some of them are pilots. We've got some regional funding, also trying to fight for some national funding, but at least we'll get started with regional funding. All the 26 are interested and are involved. And we have now started local pilots on some safety packages, that is like if you are falling out of bed, there is an alarm going. If you leave your house and don't come back in some hours in the night, then there's an alarm going, and so on. And also local procurement. When the municipalities are building new elderly centers, they have to make sure you use the right technology, or at least you are prepared for what is coming. We are doing user testing, and we again trying to make this into checklists, where we can learn from the first pilots, and then everyone can build on that when they are doing the same stuff. And the important thing about this is also that it's a very felt need. There has been a national plan on this, strategy plan maybe. The Norwegian government says that within 2020, welfare technology should be one natural part of the elderly care and the health services at local level. And it has also been research that shows that if the level of services in the health care should be the same in 2030 as it is today, then every third student has to study healthcare. And there's no way it can be like that. But things have to be done differently. We have to use technology, and we have to do things smarter. And the local municipalities see this is important. And they are in the middle of this already, and they have seen also that the experience from the previous projects with the health messages that indicates it's very useful to be part of this. They can learn a lot and then can get the quick start. And of course we are running seminars and running kind of knowledge forums within this. But again, we are now really just reiterating the models and the organizations and the methodology from the previous project. And I think also now when it comes to our project here, the improved project, this is where we will do our cases or our pilots, and we can feedback, can bring in the learning from your regions and try to improve this and give feedback again to the project. There are some references here. It's a small English summary made by my colleague Hilde Corneliussen. You can find that at our website, or I can also send it to you. And it's a report summing up all the evaluation. That's unfortunately only in Norwegian. But for those able to read in that, it's also available. So that's all I think for now. Yeah, that's the next. Okay, I think we have used my time. So maybe the next will be some questions or comments. So this is our key case.